Good afternoon, all. Welcome to the last session of Foundation Course in Palliative Nursing. Today we are going to discuss. Today we are going to discuss on the most important topic, that is end of life care and medical ethics. We do have our faculty and facilitator joined here with us. For today's session, we have Dr. Radha Venkatesan as our faculty and Sister Sheba as our facilitator. For further session facilitation and faculty introduction, I invite Sheba ma'am. Over to you, ma'am.
Thank you, Senior. Very good afternoon to all. Happy to see you, ma'am, again. Good afternoon. So, as Senior said, today we are going to discuss about end of life care and medical ethics. So, all of you know, this is our last session. So, this is one of the most important session. We already learned about palliative care and symptom management, how to communicate with the patient, that all things, nursing issues, all things we learned. Now we are in the end of the session, end of life care. This is also is very, very important. Today we have Dr. Radha Venkatesan with us. She is a anesthetist, international anesthetist, and also she's a pain physician as well as a pain and palliative care physician. Since 2018 onwards, she is working in the field of pain and palliative care. And also, she is one of the most important person in Pallium India. Now, is most of the time she spent with us, at least the online training, teaching faculty. So, ma'am, thank you very much. It's over to you, ma'am.
Thank you very much. Thank you for the introduction and giving me the opportunity. And a big thank you to Palim for taking me also as part of their family member. It's a pride and privilege to be part of Palim. And as Sister Shiva was telling today, you've all learned about what are the symptoms, what are the nursing element, or what is that you need to know about palliative care. But above all, everyone will think, when will this palliative care, when should I do, what should I do? Is that right? Is that right to my conscience? Is that right to patient's conscience? This is something a very tricky, like we say, a gray area. Because why it's a gray area? Because many things are not clear. So that's what we are going to try to do today, to clarify a few things. Most of it we know, but we are in a bit of a doubt whether is this right? Is this the best? So that's what we are going to go through this session to help you all to make a better, clear decision and be happy to move forward and work and render palliative care. Okay, with that, I will go ahead and start to share the screen, Senia. If I have any issues, then I'll get in touch. Okay. Hope.
Okay, ma'am.
Can you all see the screen?
Yes, ma'am.
Okay, ma'am. Yes.
Yes, thank you, dear. I'm going to share a presentation which has been done by Dr. Sridevi. So, as I said, we will feel free. Like, I'm happy to go through, and if anyone has any queries, you can stop and ask at that point of time, or type in the chat box, or either way is fine. Okay, I don't mind, because something, if it is really a burning question, you can ask in between. Otherwise, we'll go through and then we will see how it goes. Okay. First, as we have seen, today we are going to see a bit of both. What is end of life care and what are the ethics? Both we will see. We have some case presentations and things like that in between itself, just like because some cases, if you see, because that's what you'll see, that may give you more light on. So what are our learning objectives? discuss transitions in an illness trajectory of life-limiting illnesses. Then explain the principles of biomedical ethics and their application in end-of-life care. Then explain the existing legal provisions, national level policies that are available to facilitate end-of-life care provision. And discuss the concepts like what is life-sustaining and life-sustaining treatment, do not attempt resuscitation, futility of care, withholding and withdrawing treatment, and what is advanced care planning. Okay, what are the transitions in chronic illness? Why is this like end-of-life care or palliative care? Why is that important? Because in anyone's life, there are different phases of life. So like that, we have phases in the disease also. Like, for example, phase of life, by what you mean? We are all born as a child, then you become a teenager, then an adult, and then old age, like that. So those are the phases. Like that you have in the illness also. Early stage of the disease. And we'll take something very simple, like chronic lung disease. So initially, first few days, some allergy, they won't find out what it is. Then they will find after like few years, oh, either as an asthma or something, asthma or like emphysema, something is diagnosed. Then it goes on. With the disease, they live like in their adulthood or something. Then slowly what happens, the same thing becomes chronic obstructive airway disease or chronic obstructive pulmonary disease. So this, I have took respiratory as an example. This can come in all our systems, like cardiovascular, renal, everything we know, cardiovascular, congestive heart failure. If it is renal, it could be a end-stage renal disease, needing dialysis, like that. So I have took pulmonary just as a simple example. So when it becomes chronic, some patients live with it for a few years. So then slowly they will get used to it. Or they will use inhalers regularly and then maybe use nebulization. See the transition. Why I'm giving this example is for all of you to understand what does this transition mean. So it goes on like that. So first, very little, just allergy, then asthma, then proper lung problem. Then it becomes chronic. Once it gets to the chronic stage, from here only you all have to concentrate. It's a chronic stage, but we have something called as acute exacerbation of the chronic disease. That means what? Already they have the problem. But again and again, they will have some episode where they may need nebulization or they may need hospitalization. So then it comes to the decompensation. If you see in this, that is where it starts. Life-limiting illness. So dependency and symptom. The same inhaler I'm using, but it's not giving any relief as it used to give before. Okay, so those are the stages. Then we see if the acute or chronic episodes are becoming frequent. They were getting that symptom maybe once in a year. Then it will transform to no, they are getting this type of episode once in 2 months. Then once in 15 days. So that is where the dependency and symptoms are becoming more than them being normal. Then decline. Then comes, that is when from there to decline, this will give an idea for you to find out where the decline is coming. Then comes the death or end of life care and things. Okay. So this is what is meant by transition. So like I gave an example from baby to old person. This is the transition which happens in a particular illness. Okay, before we go on to this, I would like to share another thing. Just give me a minute. Can you all see this screen?
Yeah.
Okay. Why? This screen, the important thing is this. You've got 4 types of graph here. This is called as trajectories in any illness. Okay. I think all of you have been knowing what is the x-axis and y-axis. X-axis, the one where you've got the function, and y-axis is the time. Okay. In all these 4 graphs, function is the x-axis and y-axis is the time. Okay. These are the 4 common trajectories of illness which has been told and explained in great detail. And then there is information, data, everything available for this. So this is a very, very important thing. I would say regarding like, I will explain. If anyone has doubts, please ask at this point before we go ahead. Because see, first graph where you've got sudden death. So what happens in that? Someone, like we saw the transition, no? Someone could be like the functionality could be very good. Oh, they were doing everything by themselves, 75, 80-year-old. Sudden death, suddenly one massive heart attack. Or some episode, mostly cardiorespiratory, something which happens, embolism. So many things like that, hemorrhage. Again, all this I give example in all system to say it is just not in one only, not to blame, like many system involvement can lead to this. So sudden death is something when, for example, cardiovascular compromise or myocardial infarction is a very common thing. Okay, what happens? So someone is okay, suddenly they have a chest pain or heart attack and they die. See the graph, they are maintaining their efficiency all along and suddenly it's a steep fall. This is the percentage of how many will have this type of episode is only 7 to 10%, they say. And one thing they always say, it's really someone's all punyam or all good deeds, what they have, because 7 to 10 is a very, very small fraction. Okay. Or that is something which everyone wishes. I want to keep on doing everything and drop down dead. Okay. So something like that. So this trajectory or sudden death is said to happen in 7 to 10%. The next, see the graph on the right side, which shows terminal illness. Oh, sorry. Okay, which shows terminal illness. In this terminal illness, an example for this is any form of cancer. That is commonly we say, because why? They are okay. You see, again, the functionality is quite good. But the drop down is not just like sudden death. But for example, if someone is diagnosed, a 70 or 80-year-old, where they are diagnosed, maybe they are diagnosed at stage 3 or stage 4 of the malignancy, they have few months. So that, and their condition, see, even though they were having very good functionality, it drops down. It's called as a waterfall effect. You see, somewhat similar. Like, why all these examples are given? Because to relate to something that we already know. That's why all these examples are given for us. So that makes more sense. Like when you see a waterfall, what happens? It falls from that height, but that falls down. So something like that. They might have been very good. Suddenly they're unable to do things. They're going down, and then they finally end up dying in a very short period of time. So that is trajectory 2. Then you have trajectory 3 and 4, where we have to give more importance and understand. Okay. Trajectory 3 is something which trajectory 2, they say could be 15 to 20%. Okay, I said trajectory 1 is 7 to 10%. Trajectory 2 is like 15 to 20%, something like that. Whereas trajectory 3, where it says organ failure, that is where you will see a large number of people could fit into that. For example, whoever has any, nowadays we have non-communicable diseases. Okay, it could be diabetes, hypertension, heart, liver, lung, neurological, any such organ failure. Okay, so in this graph, please have a note. So similarly, you have function. Whereas, see, to start off itself, their function, if you see trajectory 1 and 2, their function is quite high. Whereas in this category, to start off itself, their function may be slightly lower. Maybe not 80, 90, 70%, something like that. Why? Because of the chronic organ failure disease. For example, diabetes, they've had diabetes 30 years. They may have some problem with the eye. some amount of peripheral neuropathy, they might have had ulcers. So what you have to understand is already because of the organ failure, some amount of their functionality is already affected. So if you see that, to start off, they are at 1.x. Okay, they have one episode of some problem. For example, they end up with an infection, diabetic ketoacidosis, they get admitted. Okay, what happens? You see, when to start off, it dips down. Okay, they get into ICU, they get into very best medical care, and then they get better. Okay, but what happens? Slowly, if you see the next graph, they started off at X, they went down. When they came up, they are not at the point X, they are slightly lower than X. And then in duration of time, the whole graph is going down only. It is not even staying at that level. Okay, and then what happens? One more episode of again an infection or a UTI. Okay, so again dip down, they go have 2-3 culture sensitivity, antibiotics, everything is given. So, okay, they get better. So if you see the second steep, how much below, if you put the corresponding line to the functionality, already the functionality is low. So to important take home from trajectory 3 will be to start off, they are at one level of functionality. Every episode of their illness, they become all right, but they are not up to the previous level. So that is how the decline is happening. So gradually it goes down, 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 and then that is how. This is one particular type of trajectory. This, they say, nearly 50% may also fit in this. Okay, anyone above 60 years, this is the very high probability trajectory. Okay, the fourth one, which is the frailty. There you see the function, where the function is already like 80, 90-year-old. Gradually they have declined. So their functionality is way too low. And in that itself, it keeps on going further down as age progresses, because all system, organs, everything, wear and tear. As we all age, we will all get that. So this trajectory is something, it's a very, very gradual decline, because the functionality is at a very low level. That is how it goes and goes forward like that. Now we will come back to our presentation. Okay, now this main thing why I wanted to explain about those 4 trajectories is that will cover the whole, all patients you see will fit into one of the 4. Okay, so that is something to know about how all it can happen. Okay, so that is the main important thing. We will go through the rest of the presentation, and then little bit more about end-of-life care also we will see. Okay, now when you come through this is all, these are the 4 types of trajectories we have seen. So we can have patients fitting into any of them. When we see patients, what are the queries and doubts and things that are going to bombard us in decision making? Okay, to help us in that, we have something called as the cardinal principles of medical ethics. So whenever I do, am I doing the right thing? Is that what the patient wants? Is that what I want? So when you have all these, see, because as I've told you, so many variety of patients you can see. In the decision-making situation, what is that that's going to help us? For that, we have very important cornerstones, which are the 4 important things are autonomy, beneficence, non-malfeasance, and justice. Okay, so these 4 things, we will go in detail, but these are the 4 important things: autonomy, beneficence, non-malfeasance, and justice. And always one more thing which is added is dignity to the patient, and giving them a comfortable, convenient death both to the patient and caregiver. all that is also incorporated. Okay. And the three underlying points which mainly you have to keep in mind to be able to do the four cardinal principles are truth telling. Okay, the most toughest job, or no one likes someone who speaks the truth, because it is core important thing. And like always, as we say, facts and figures are very hard to digest. But that is one important skill for us to develop. First is truth telling. Next, respect for life. Respect the other person's life as you would respect your life. Next, respect for the person. That's what, as I said, dignity. As we say, when you're alive and you're doing anything, you look so much for your self-respect and dignity. Should you not give that same self-respect and dignity at the time of death also? So these are if you remember these three, managing and doing the four cardinal principles will be easier. So that's what: dignity, honesty, and clinical integrity. Okay, we'll see these through some cases. Case 1, 78-year-old woman with stroke, hypertension, and type 2 diabetes. She's cachectic, bedbound, and dependent on all activities of daily living. Brought to the hospital with reduced urinary output and reduced oral intake. She was diagnosed with urinary tract infection and end-stage renal disease. Okay, and she was advised antibiotics and dialysis. But what did patient say? Patient refuses. But family all say, no, we want to do everything for her. Sons want her to undergo everything. But the patient says, no, I don't want. I've made up the decision that I don't want all these things what you're offering to me. Okay. So what would you do? Will you advise the patient and coax her that you should have dialysis? Or will you avoid talking and discussing the treatment to relatives? That is, you will do everything with the patient and ignore the relatives? Or will you respect the patient's wishes? Or you say, no, this I can't manage, I will send her somewhere. What is the thing? One second. Sorry, dear. 1 minute. Let me go back. Just give me a minute. Why am I not able to go back? Sorry. Sorry, Sinia, just give me a minute. I'm unable to go back on the slides. Just give me a minute, okay?
Sure,
Okay,
ma'am.
ma'am. Okay.
Ma'am, you are muted.
Siri, sorry. Okay, yeah, what I wanted to ask is, can I leave it like this? Can you all see clearly so that when I go to presentation on my device, it's not allowing me to move slowly? Okay.
It's clear, ma'am. We can all see.
Okay. So basically, does anyone want to raise any issue and say, what would you do? Would you advise the patient to, even though she doesn't like or she doesn't want dialysis, will you force her to have the dialysis? Anybody wants to say anything? Or if anything is there in the chat, Shiva, please have a look and let me know.
Sure, ma'am.
If there's nothing on the chat, then I will move forward. Okay?
Will respect patient's wishes.
Yeah.
Somebody wants to ask anything?
Yeah, ma'am. One chat is there. Respect patient wishes.
Very good. Okay. So that's where we are coming to. Okay. That is exactly well done. For the person who said exactly that is what we have to do. Okay. The family wants the best for her. We don't deny. Okay. But what is the best for her? Oh, and at that point of time, not only what is the best for her, what is her wish? Okay. So that is where it comes. What is autonomy? We are going to see here. Who makes the decision? Should it be only patient, or should it be only doctor, or should it be family? And in that case, social, what is the expectation? What will others say? In all those situations, the patient is the one who has the highest right here. Okay. In that situation, something little bit more we have to understand. Patient has the right, but sometimes it will come. It may not be always the same. Sometimes patient may not be completely educated, may not understand. So they may say something like that. No, she doesn't know. So those type of situations, the doctor or the medical team's responsibility is to explain everything to her. After that, still the decision is the patient's decision. Here in this case, she is clear and she's telling that she does not want. Only thing we have to make sure that is she aware? Does she understand what is the situation? What will happen if she goes and does the way she wants? We have to explain everything. And if it is clear that she understands, always her decision is final. So that is what is mentioned here as the capacity. What do you mean by capacity is the patient conscious oriented, and has she understood? So if she says no to this, what will happen? Her health may deteriorate. All that you explain, and then still she says, yes, I know, this is what I have decided. So that is what. So ability to understand the situation, ability to appreciate the choices available, as I explained, ability to reason the benefits, burden of treatment, all what I have explained to you, ability to communicate their goals and aspirations. So if they have all that ability, then that is fine. So patient has the final full power to make the decision. So respect what are all important? Doctor-patient relationship, respect for patient privacy and confidentiality, empathetic truth-telling. So you clearly explain everything. And as I said, sufficient. You should tell, if you do this, what happens? If you don't follow this, what will happen? And then if there at that point of time, any doubts and queries, you have to clear. And then any cultural issues, beliefs, no, I want to follow this. For example, dress code, all those things, they may have different issues. We have to respect everything at every point of time. So that is where the doctor-patient relationship matters. Okay. You give all importance, explaining everything, and then make a decision. And every region, every part of the world has something different. Okay. Especially in India, it is collective autonomy. For example, just to give you all an idea, like in the Western world and in the Eastern world, there's a big difference. Okay. For example, in the Western world, patient has full decision making. Sometimes the patient will not want to tell it to others. So there also always patient is given the full autonomy. Okay. So if the patient doesn't want to tell it anyone, that is confidentiality. Okay. And they themselves are happy to make the decision, that can be done. Okay. Similarly, if you take the Eastern world, like the Indian culture, all live together. Okay. Like a father, mother, children. Not only father, mother, children, you have extended and a very big family. Sometimes they may be close to someone out of the family also. So that is why here it is said as collective autonomy is the norm in our culture. That means what? You explain everything. And then the patient may say, no, I will talk to my son and then collectively we will make the decision. So only thing we'll say, you don't be afraid. You need not be forced by anyone. So we give all privilege and explanation to the patient. And then that collective autonomy is meant by a collective decision is done. And again, only in the best interest of the patient. So patient's autonomy is maintained through this collective nature. Okay. So that is what is explained here. And when you have the conversations, this is important, what is explained in this. So I am expert, you are. So as the doctor feels that he is expert in healthcare, the patient is expert in his life. Okay. So that is why we always say patient's autonomy is upheld. So the patient's best interest, it is said. So that is what is explained in another pictorial way here. Okay. Next comes, if the patient, here the patient is all, can understand all. If suppose you have a patient who is, as I said, no, who is not conscious oriented, who cannot make the decision. This patient has dementia, lacks capacity for decision making. Then what happens? Okay. There you come. Already they might have, when the patient was getting into the stage of dementia or something like that, in some situation, they might have already had a surrogate or decision maker. Because see, this happens in many situations. Sometimes the patient themselves or the family, they might have nominated someone, or they might have even done a legal document for the best interest of the patient. So in that only you have another type called as advance directive. Advance directive is something called as a living will or medical power of attorney. Basically, they are done by the patient as a legal document before itself. See, all the transition of illness, why did I explain so much? When the condition is deteriorating, we all have something called as a gut feeling. Okay. Oh, something is not going right for me. I've not been keeping up how I was. So many situations, the patient themselves make a decision. Maybe if it is husband, wife, they might have spoken to them. Or if it is the parent, children, they might have told, see, I'm not getting okay as I was getting okay before. So I think I make some decision. So they might have done a legal document. So nowadays in those type of legal documents, it is said, we will see a little bit more, but I will give a little example. In those legal document itself, you can make a decision. I don't want ICU. I don't want NG tube. Because many people are aware of many things nowadays. So these advanced directive or medical living will, all those things, no, medical power of attorney. See, it is like similar thing like you do with any power of attorney. What is power of attorney? You give the power of your decision making to somebody else. Okay. So the same thing, because based on the condition, if the patient can't make the decision, then the power is given to someone. This they could have done before itself. So that helps the medical fraternity to make a best decision for the patient. Okay. So next comes, so this is one of the ethic. Next comes, what is beneficence? So basically, just to keep it simple, beneficence is doing good. Okay. So mainly the doctor has, or as a medical professional, doctor or nurse, what do we always see? We want to do the best for the patient and always what is good for the patient. So in that, we always try to see, as I already said, in the best interest, then am I fixing what was wrong? If it's an infection, am I giving the antibiotic and correcting the infection? And am I managing it properly so that the disease is going to get better and not get worse? Then here important thing comes, risk benefit ratio. Whatever treatment we are giving, is it causing more benefit or causing more risk? So at that point of time, you should try to do what is giving more benefit rather than what is giving more risk. Okay? Or am I simply delaying the inevitable? I'm just trying something, but nothing is progressing in the right way. And what is the expected prognosis? What is the survival? Like that's why no stage of the disease, staging of the disease, or to reassess them regularly to see if they are improving or if, are they going down. I'm doing everything, but they're going down in the opposite direction. So those type of things always to see and try to do the good rather than cause any, if they always do something which is more beneficial than causing more risk. And at that point, palliative, if I'm not doing anything good, that is where the thought of palliative care should start coming. If I'm doing everything, it's not causing benefit, causing risk. So at that time, where do I see? There, that is when a collective decision is made to look at, can I do something to be supportive rather than be curative? That's where palliative care element could be introduced. Next, another case to see. A 20-year-old boy with metastatic osteosarcoma of lower end of femur with lung metastasis and anemia. And he has a large tumor on his thigh and insists on getting operated. Both parents and the patient is adamant that they want the operation. What should the surgeon do? See the diagnosis entirely there. 20-year-old metastatic osteosarcoma with lung metastasis and anemia. And it is a large tumor. So there, generally to see what are all the outcomes. If you take that person for surgery, will he cope with the surgery? He is already anemic, okay, and already has lung metastasis. Will he be able to cope with the surgery? Then comes the post-operative care. So will he be able to withstand the surgical insult, we say. So if the parents and patient know, because it is causing so much harm, whether that is where, as I said, no, in these type of situations, risk benefit. Okay, we'll see what. So when you go to that state, see here, as I was explaining, what are the benefit, what are the harm. So the benefit, okay, as I said, because it's a big tumor causing so much discomfort for him from walking, moving, everything. So debulking, psychological. So it's such a big thing, so causing disfigurement. But see the harm. As I said, already is anemic. Will he withstand anesthesia? When that is taken, there may be more pain. Will he cope with it? Okay. So that is where here you have to say, you have to give all information. They may want surgery, but you have to explain to them the benefit and harm, and then come to a collective decision. So that's where many times they may think, oh, we are asking, they're not doing. If you don't explain, they may think like that. But if you explain that decision, if you explain all these harm, then they will think for a minute. Oh, the benefit is less, the harm is more. So let me think. So our job is explanation. So non-malfeasance means what? Malfeasance is to do harm. The literal meaning of malfeasance is do harm. Non-malfeasance is not to do harm. So as we saw the 4 cornerstones, we saw beneficence is do good. Non-malfeasance is do no harm. Our job is to do either to help and cure, or at least not do harm. So in these things, when we saw the harm was more than the benefit. So that is where our job is to explain both. And then, so first, our responsibility is to not to do harm. Respect sanctity of life. Non-malfeasance is the right of the physician. We have no right to do, like negligence. No, if you do harm, that is. So our main job is to not to do harm. So, and sometimes in these type of things, there is something called as doctrine of double effect. Just I will touch on it. Basically, when you do some procedure, multiple actions will be there. One action may be to help. As a result of that action itself, there may be some little bit of like side effects. But at that point of time, that's why it said here, allows for doctrine of double effect. A treatment intended for good unintentionally causes harm. Okay, so that one, the intention is given importance. Without causing any harm, you do something, but as a result of it itself, it might cause some other side effect. So at that point of time, the side effect will not be blamed. It is done in the good intention to help the patient. So that is what it is. So basically, non-malfeasance means not to do any harm. That is the important thing. Then a little bit about doctrine of double effect. Single act having two possible foreseen effects, one good and one harmful, is not always morally prohibited if the harmful effect is not intended. Okay. The example is performing salpingectomy in ectopic pregnancy. You're saving the mother, so that even though by doing salpingectomy, you may think, oh, she can't conceive. But if the mother is alive only, she could have another option of having another child at least. Okay, so this is a very good example. And similarly, when, for example, another simple one is midazolam. Sometimes, because in your practices, you may see, it is given to help the patient, but sometimes it may cause a little bit of drowsiness and things. So that is why many things will have two effects. But the second effect is not the main intention. The first effect of helping them in one particular way is the main intention. So that is what is called as the doctrine of double effect. The next example case, a 57-year-old man with advanced metastatic cancer of the lung, severely breathless, mainly due to the progression of the disease. All reversible causes of dyspnea has been ruled out, and he's admitted into the ICU for artificial ventilation. What do you think about this decision? Anyone wants to say anything? If anything is there in the chat box, please let me know, Shiba.
Sure, ma'am.
See, these topics are a bit of a heavy stuff, but it is important as, like, see, from nursing point of view, important thing for all of you to know is the decision is made by the multidisciplinary medical team. But all of you have to be aware. And many times you may think within yourself, even though you might not ask, oh, is this right? What they're doing is right. I am also part of the team. Is it okay? Is it good to my conscience? So these type of queries will be there in every human being. Okay. So the important thing for all of you to take is that to be aware, and it's a medical decision being done. And there are so many ethical grounds which are kept as a base for doing this. So that is the important thing. So in any queries you have, please do ask. But if you understand overall what are the things, that will be more than sufficient to help you to render the service what you're going to give with a calm and peaceful, satisfied mind. Okay, then let's move forward. Okay, because we saw with the case he's nearly progressed so bad in his illness. Do you think we should admit this patient in the ICU? Should we intubate him? And should we resuscitate him if he has a cardiac arrest? Okay. Now comes the fourth element. Justice or resource management is what comes in this fourth important thing. So what is it? Generally, overall, some salient points to be understood. All these which are given here are quite important. Healthcare is a scarce resource, okay? The whole world, not one part of the world, the whole world is screaming that health expenditure is something big, which is absorbing the whole economy, okay? Why? Many reasons. I'll just give little bit of general statistics, okay? Why? Because of late, many parts of the world have different type of demographics, they say. In some parts of the world, there are people who are more than 60 forming a big part of the population. In some parts of the world, it's a balance. They have a population which has young and old together. So the demographic of each country has a big role to play in this. Okay. So when in those type of situation, so the whole country economy, how much of funds and money is there to be spent on healthcare? So that one element is there. Next, equitable access to resources. Does everyone get, is everyone able to get ICU care? So that also is not possible. Like all is like what to say, government healthcare is provided for everyone. That is not possible, mainly because of the number. And then this COVID was an example for that. Okay, everyone wants ICU means the generally itself ICU, if you see, it is only 10% of, for example, any 1,000-bedded hospital will have 10 ICU beds. That's all. They will not have 1,000 ICU beds. So these are the general norms. So there is, it's not a equal. Medical ward and ICU are not same number. There'll be for 200 ward beds, but only, like as I said, 10 or 15 ICU beds. Okay. And then next, are we allocating that precious resource of ICU justly? 20-year-old is there, 80-year-old is there, 20-year-old, some issue has got it. So like that, are we allocating it justly? Are we considering, that is one element. Fourth element is very important. Are we considering the family resources? Okay. Already one person is the earning member. There is some more people to be looked after. That in those situations, it has to be a wise and just decision. That is where you have to put in everything. Autonomy, beneficence, non-maleficence, then finding out which transition or trajectory of the illness there. That's why the collective medical decision is important. Then comes risk and benefit. So try to do something which is more beneficial and that rather than causing more risk. So what is ethics? Ethics is knowing the difference between what you have a right to do and what is right to do. Okay. So that is what, because I'm a doctor, I have to do everything. That is not the way to go forward. What is the best for the patient at that point of time, at that stage of that person's disease? Everything has to be put together and then a decision has to be made. Okay. Next, ethical decision making. What is justice and how? Few more we'll see into that, so that it is clarified for all, not to worry where I am doubtful or anything like that. End of life care consumes 10 to 12% of all healthcare expenditures. That is why not only, and that's why they say medical debt. It's also said as medical debt. Many people know, like when they have this type of long drawn illness, few lakhs of rupees are spent. That might be their lifelong earned money. So that's why this 10 to 20% of expenditure is just spent on end of life care itself. And then physician's duty to an individual patient and to society as a whole may conflict in cases in which limited resources are disproportionately consumed by a critically ill individual. Okay, as I said, no, like this age difference, as I said, you have to see whether is that patient the appropriate patient. Will he benefit? Main thing what we have to see, okay, first is to see appropriate. That patient should benefit from going into ICU and getting better. You have like a terminal illness which will not improve at all. Will that patient benefit from going into ICU? So that is where. So assessing futility then becomes imperative. This is important to the previous statement. Yes, I have ICU facility. I can use the bed and use the resources, spend so much money. But is the whole event going to be successful, or will it be in vain? It will not have any impact, no change. So should I use it properly? Is it justified in using that? So that is where all these have to be considered. So at that point of time, no futility. See, in one of the cases we saw, are we trying to do something which is inevitable? So excessive, aggressive medical interventions in terms of efforts required and financial resources utilized, having little or no effect on clinical outcome. So whatever you do, the patient may not survive. In those type of things is what is explained by the sentence. So you have to know that's where the prognosis and progression of the disease. So for that only, whatever the state is that does not slow the disease progression, will not sustain life, will not reduce disability, will not improve health or discomfort. So that decision, when it is made, that is what is futility. Whatever you do, it will not improve. So even for investigations, what we say is, if you do an investigation and it is going to change or give a better outcome in the disease, only then you should do an investigation. Just for the sake of doing an investigation, you should not do. That is just waste of money and resources. Okay, you should do something. Oh, I did this, something was picked up, I did some intervention, it caused some benefit. So that is to be kept in mind even for a blood test or anything. Then comes your money spending in ICU. So for these attitudes and values have to change in each one. See, when it is possible, for example, as I said, if it's a 20-year-old, everything, no disease, no problem. So that means it's a first episode. I will do 200%. Okay, because there is no futility. There are more chances of them getting better. See, similarly, if it is a 20-year-old with end-stage disease, as we saw, so you have to put everything. It is just not the age. It is just not the disease. It is just not one factor. You have to put everything together and make a collective medical decision, whether it has what progression or what track it is taking, and accordingly make a final decision. Then comes foregoing life-sustaining treatment. Treatment that does not provide net benefit, as we saw, ethically, legally, or whatever it is, be withheld or withdrawn. See, withheld, withdrawn, they are same. Little bit of wordplay. Okay. Goal of medicine should shift to the palliation of symptoms, where you've got what we saw before. We are in a state where futility is recognized, and then there only, I said previously also, I mentioned, when you are in that state, that's some ideal time if they have not thought of palliative care. Nowadays, what we teach about palliative care is palliative care starts from the diagnosis. Okay, it goes hand in hand, where corrective treatment may take a bigger role, palliative care will be in the background. When the disease progresses to a stage where corrective treatment is not effective, then palliative care role increases. That is how is the general, that's the best or ideal palliative care. But that doesn't happen in all places. Many times they are not even aware of palliative care. So in those type of situations, when futility comes, that is the best time to introduce and to explain to them, don't worry, don't think that nothing is going to be done. still we will make sure that all symptom care, symptom support, everything will be done. We will be with you to take you through. So that is where palliation is meant. The goal of medicine should shift to palliation of symptoms. Then no ethical difference between withholding or withdrawing. Next is, what is CPR and is it legal and things like that. Cardiopulmonary resuscitation is CPR. Then everyone will have this doubt. Oh, euthanasia. So euthanasia is different. Euthanasia refers to intentional act of ending a patient's life by medical means. And that too, how at the request of patient, family, with an objective to end or avoid suffering. And euthanasia is not passive and it is deliberate. It is illegal in India. Okay. Withholding and withdrawing life support in a patient with terminal illness nearing end of life is not euthanasia. Okay. So that is different. This is different. Clearly, withholding, withdrawing is you're not continuing, like putting on the ventilator, going on doing everything. That is withholding or withdrawing. It is not. So this is something which has been very clearly explained, and people all have to understand. You will all get the presentation, no? You will all get. So have exactly, euthanasia is not passive, it is deliberate. Whereas withholding and withdrawing is nowhere near euthanasia, okay? Here, we will do all supportive care. Not that we are not going to do interventional care. That is only not done. So it's nowhere similar or nowhere near each other, okay? So that is something to be understood. And then next is few things regarding the legal and things what is available is, see, one important thing what I would like to say here is before we go into all these legal aspects. See, overall, no, the legal fraternity is there to help us so that the patient, doctor, everyone is able to make a decision in the best interest of both. See, if some advance directive is there for a dementia patient, the patient also is able to get the best. And the doctor has the freedom because already some decision is made that, for example, a dementia patient has decided that they don't want ventilation. Okay. So when one such patient comes, you still do everything, do supportive care, do whatever is best, symptom care, supportive care, all is done. Patient is kept comfortable all along until the patient dies. So it is good for the patient and the doctor is also comfortable because all legal documents are there. The patient is safe, doctor is also safe. So all these legal elements, policies, guidelines are there to help the whole patient and the medical field. So that is what has to be understood. So let's see what are things here. The right to die with dignity is the fundamental right as already declared by the Constitution, bench judgment of the court. And we declare that an adult human being having mental capacity to take an informed decision has right to refuse medical treatment, including withdrawal from life-saving devices. See, these are very important things. Okay, but for all these things, patient, family, or mainly the patient has to be aware of what are the things available. As I said, no, it is a big responsibility of the medical profession. We have to tell what happens. So many times, sorry to say, I am one person who will say, oh, I don't have time to explain. That is not right. Okay. Part of our job is to take time and explain. I said truth telling. First, what was mentioned in the slide when we started off with medical ethics. So it is our responsibility. We have to spend time. You can't say that I don't have time, I have to see so many patients. Okay, you have to see 20 patients, see the patient, ask them to wait, take after finishing your clinic or whatever it is for doctor or nurse. I would say, no, all of us have the responsibility. And then it is our job to explain everything to the patient. Even as a nurse, you can tell, see, none of you have to be scared, okay? Anytime you feel not okay, you are part of the team with the doctor. So you have to tell them, so no, this patient needs more information, or at least find time for the patient and the doctor. So all of you have got all the rights. Be bold. Anytime you feel not okay, you have, because it is the right of the patient or doctor. As human being, all of you know, all these things you have to consider the patient. Like anyone can be in that patient's place. Today that patient, tomorrow one of your kith and kin or one of your relative or one of us can be in that patient's shoes also. Okay, so those type of things we have to take time, convey the message, and then the final decision making is in the patient. So an adult human being of conscious mind is fully entitled to refuse medical treatment or to decide not to take medical treatment and decide to embrace the death in natural way. So all these are important elements. These are made easy. Okay. And what is the essence of recent Supreme Court judgment? An advanced medical directive. This is called as living will. This is there in the whole world. Is an individual's advanced exercise of his autonomy on the subject of extent of medical intervention that he wishes. As I told, no, he can decide even on his own body at a future date when he may not be in a position to specify his wishes. As I said in the beginning, no, the transition or the trajectory of the disease slowly may be getting worse. So this patient might wish for something. So that is what is advancement. They write that and keep. It's a legal document. If someone makes an advance directive or a living will, means that has the biggest power. Their next son comes and says, wife says, nothing will work. Okay. The purpose and object of advanced medical directive is to express the choice of a person regarding medical treatment in an event when he loses capacity to take the decision. This is the important thing. Okay. At point X, he has all the capacity to make the decision. But at point Y, when he's very sick, he may not have the capacity. But for that condition, he has foreseen and he has made the decision like this. So this has full right, full value. So this is available everywhere. It is available in India also. So that can be done. Living will, that's again a legal document created by patient explaining and documenting their wishes. That's all. Living will, advance directive, they're all the same. And that explains what is the medical treatment that they wish when they become incompetent and unable to communicate or anything like that. So use this. Okay, this guides the medical profession and family about medical care. That's why, as I said, no, once it is made, it makes the person's life and the family's life also easy. And these are all the things available in the website. Palim website has, and there are so many many things are done. Like there are end of life care guidelines. There's a community, and in that you have professionals from different specialties. Okay, they're all part of the steering committee, so that it is just not one. Like general medicine, neurology, everyone is there, so that all elements are incorporated in that itself. So here what all is mentioned is, you have an end of life policy from Manipal, you have an ICMR guidelines, there are more information. This, as I said, the Indian Chamber of Commerce and Industry. So similarly, there are many such things which are available. And then main thing is that clinical integrity, ideally, the dignity of the patient profession. So no one has to talk ill of the doctor or anything. If everything is done properly, sometimes you have rough relationship between the doctor and the patient. That we need not have. Okay, if you are going to be clear and convey all the information, that, see, and always say, this is medical decision. Why and how are we making, with like 25, 30 years of experience, with you give them figures. Okay, this many patients are seen. This 50% only is the outcome of coming out of this, or 80% success is not there. It is futile. With all these parameters, so many organs are already not working. All that you explain and give detailed explanation. Don't bluntly say, no, nothing will happen. Then they will think, oh, you're not explaining to me. How can I believe you? So that's why any doctor, nurse, or anyone, so you have to explain things clearly and have a nice relationship. So maintain dignity for the patient and the profession. Be truthful and honest. Informed consent and truth-telling. See, truth-telling, we are telling again and again. Important. And communicate what you document and document what. See, this is very important. Oh, I said everything, but I never wrote anything in the notes. Why do we say as doctors and nurses, you have to document? Because what you said, what the patient heard, everything may go in the air. Oh, I forgot. But what you've documented is what will save you. So documentation is very, very important. You cannot say, I don't have time and things like that. Everything is important. So the nutshell, main 4 things, what I would, important things like take home, what I would just like to say is that 4 trajectories, which I mentioned: sudden death, terminal illness, chronic disease, and frailty. That is something to be kept in mind. Okay. And then the 4 important cornerstones of ethics are autonomy, beneficence, non-malfeasance, and justice. Autonomy is the total right of the patient. Beneficence is do good. Non-malfeasance is do no harm. Justice is use the resources and everything as justly as possible. Okay. And there may be, in many situations, there may be like not only one element of the ethics, 2 elements can come and clash. One can clash with the other. Like as we said, autonomy and beneficence. Like patient says that I don't want. Others say, no, that we want to do good for the patient. Simple example is feeding. Okay. Normally they say, oh, they are not eating, we want. But many situations, what happens in chronic illness and disease, the patient has lost appetite. They don't even have they can't even swallow. So those situations you have to explain, and the patient is in such stage where just feeding is not going to help. It may cause harm them. It may cause cardiac overload and pulmonary edema. So you have to explain things. So just food alone, when the patient is fine, eating well, doing everything, that is different. So this, I gave an example because there may be compromise and difference of opinions. If you explain, everything will be made clear and more nice for both the patient, doctor, and the whole setup. No one, for all the service and care that you do, you don't want to be upset or unsatisfied at the end of the day. Okay, so that is the most important thing, as I would say. This topic as such is a bit, what to say, multiple things, legal document and things are there. And nothing to be worried. There are so many guidelines and safeguards available. If you stick to what has to be done, follow guidelines, follow what is there in your respective hospital, then no need to worry at all. Okay. I will stop.
Thank you, ma'am, for the wonderful session. Anybody have any doubts on this, please ask.
Please let them.
Anybody?
Any queries, question?
Ma'am, one question.
I'm just seeing the chat
Yeah.
box.
Okay.
They've explained to the patient and family members natural process of death and what happened with artificial ventilation. Exactly, that's what we have seen. without putting them on the ventilator. Exactly. So not only ventilation, no, you have something called as non-invasive ventilation. If they want, just buy a mask or like a prong with the oxygen, all those are there. That's what you do. It's hard to inform the fact and convince. Yes, that's why, truth, they've said the most difficult thing is truth telling. And next thing I'll say, someone who tells the truth, people won't like. Never mind. Because end of the day, when you tell the truth, you will also be peaceful. That minute they may not like, okay? Don't worry. 10 days down the line, they will come back and feel sorry and say, this has happened, I'm not creating. Okay, at that point of time, they'll say, then they'll come back. That's why normally I always will tell them, even if I'm explaining to patient and all, I'll say, now you won't know what to ask. Go, sit and talk with your family or kith and kin, come back. Then you will have queries. Then you yourself, that's why these don't happen in one meeting. Okay, you have to spend time, and then they'll come back. Sorry, that time I was not in the mind frame. I couldn't take everything. So I was unable to make the decision. So it was helpful. When I went home and sat and thought, no, I don't want him to go through all this, him or her. So that you see, as human beings, some amount of denial will be there. And everyone need not know everything. Will I know everything about plumbing? Or will I know everything about computer science? No. And not needed. Like that. That's why we say we are here to explain everything. You may have queries, go back, come back and ask us, think, talk. But sometimes that's what these type of things, it will be a challenge. And something else is there in the chat box. Let me see. The extubation will be another. Exactly. Yes. Totally true. That, see, we always say intubation and extubation equally challenging and equally traumatic. And in a situation where you know that it is going to be very difficult to get them out of a ventilation, it is wise not to put them. Because very good thing, who was that, Shiva? Nice. Sundaravalli.
Sundaravalli.
Is that Sundaravalli?
Yes, ma'am.
Okay, no problem. Very well said, dear. Because many times, what many families feel is they don't realize initially. But when the actual thing happens and when, okay, everything is futile, nothing is going the right way, then you want to extubate. That's the most challenging, most difficult thing. Okay. So, in fact, intubation is a controlled condition. So that can be done to a certain extent safely. Extubation is, if it is not done in a controlled way, it can be disastrous. So thank you very much, Sundaravalli, for bringing that up. And something else, and I realized during the first meeting, they may show they understand that when we got new symptoms happen, then the family members will get nervous again, and we need to reinforce and reinforce again. Yes, reinforce umpteen times about patient's deterioration is not, that can be done with one. Totally true. Yes, doctor, I guess, Zhuang. Thank you. That's why we say it is not, nothing happens. Not only these type of things, even awareness and explanation, because these are all, there's a whole element, no? Any palliation or terminal is a sensitive issue. Okay, very sensitive. It has so many elements, denial and why is it me? Why is it happening now? And it has happened too quickly. How many ever time it takes and happens, it will be as too quickly only. Because their love and affection, okay, underlying all this, what is there? The love and affection is what is covered or concealed by other means. Okay. If
Doctor,
there's
I
no
have a
more, we'll go
question.
for the case presentation,
Yeah.
Doctor,
Shiva.
sorry,
And
one
then-
more question, Doctor. Sorry,
Ah.
Yes.
last one.
Go ahead.
Doctor, I'm not sure. I have no idea of this. Actually, in legal ethics, is rights goes to like end of life patient, like dying patient, the decision making, all these. F- Actually, it's falls on. Is that actually is a doctor's decision that to tell the family like this DNA for them to establish, or the family, always I go through this a lot in my settings, that the patient sometimes express their wishes, sometimes patients unable to express their wishes, but the family members are doing the decision. But what is actually
It's a very good,
in the
very good
legal
question.
actually who
It's a
has the
medical
right?
decision, dear. It is not. See, if this advance directive and living will or something, it is really a blessing if the patient has made the decision before. Okay. But if any such decision is not made, then it is more of a multidisciplinary medical decision and not a patient or family decision. If the patient is in a situation where they cannot make decision, they don't know anything about it, and the disease condition, it's this your query, it could be a patient with 5 medical issues and all like cardiovascular, respiratory, everything is in like end stage. And if the patient or family says, patient is unable to say, family says, I want everything done, will it work? So in those situations, it is not one person decision at all. Putting everything, it is a medical decision. And that too, not one doctor decision. The parent team or whoever is the physician who has been seeing the patient for so many years, then with the other specialties, and then maybe the intensive care, everything. So it is a collective medical decision. So for that and all, every organization should have a medical team set up for this. One day, all of a sudden, these things won't happen.
So by law, doctor, is decision is actual decision is from the medical side.
See, that's all.
Only the medical.
You can't just blindly tell like that. Okay. As I said, multiple factors are there. Okay. If the patient is in a condition where he's awake alert, then the doctor's responsibility to explain everything to him. And if he, like from the topic of what we did today, patient fully awake alert conscious, you explain everything to patient, their autonomy comes, he makes the decision. Next, if he can't make, then only medical decision comes.
Understand.
Okay. So all these 4 points, what we have said, you even in those times, it may be like, that's why our profession, you have to be awake alert all the time. If you stick to 1, 2, 3, 4 and don't miss anything, you will be safe, everyone will be safe. See, and then the legal things are there to help you. So when patient is fully compos mentis and things, you just can't say medical decision and do something. Okay. You have to assess the patient, explain everything, see his condition, explain to him. If he is able to make the decision, well and good. See, and always whatever possible we'll do. But if he's, like as I said, one of the example, he's already progressed to a very end stage of the disease. And then if you're going to intubate, ventilate him, you have to tell him, if he can make the decision, fine. Otherwise, in those situations, 2, 3 medical experts together will make the decision. So you can't say like one size fits all in these type of things. You have multiple things and you have the legal element also to help you. Because suddenly someone shouldn't come and say something wrong was done by this organization. That shouldn't happen, isn't it? That is where the legal thing comes. So all these guidelines and things have to be used. And many organizations have a medical team for making all these type of decisions. For DNA, or what you asked, for that also, if you take the document and see, it will have all factors. The disease, then how many, we have explained all this. It's like 2 people together, 2 doctors together only will make the decision. With the patient, if patient is awake, alert, conscious. If not, if the patient is unable to make the decision, then with next of kin, what is the quality of life? How has the patient been? Has he been, everything will be taken into consideration. Nothing is done just like that.
Thank
Did
you,
that
Dr.
make
Gauri.
any sense to you?
Yes, Dr. I
Ma'am,
understand. Thank you.
can
Thank
you give me a little advice about the morphine infusion?
Pardon me?
Some patient are wish to take that, will think that terminally ill cancer patient, they wish to take morphine infusions.
For
No,
what?
that
Yes.
Shiva will
Continuously
answer
they
for
are
that.
asking to take morphine infusion, IV infusion,
For
because
what?
of the pain.
IV.
Yes.
Yeah, ma'am. So I would like to hear from you. Why are they asking about morphine infusion?
Actually, I also don't have any good idea about that, but most of the patient wish to that they are telling that the most of the European countries they have some try to get some painkiller as a painkiller or any other things, and they are
Then,
asking about the morphine infusion.
okay, then
Where,
it's our duty.
Shiva,
Yeah,
this
ma'am.
nurse, where from she is?
I'm from Sri Lanka, ma'am.
Yeah. So I
At that
think.
time, we are doctors, and our multidisciplinary team. We have we don't know what that we have to do.
So what you can do is you have to do the proper assessment. Why they are asking about the morphine infusion, and you can do the proper pain assessment, and then you can do the needful. If they are not able to, you see, in end of life care patient, we all know that that they are not able to swallow properly. If they have pain, we need to give a morphine infusion. So that time we can think about that. If they are not not in that condition, then how they will ask for a morphine infusion. So that thing you have to explore it more. That is very
Do
very
do do
important
do
one.
do we need to take any legal documents or any other things when they
I
request
think
this?
not required, ma'am. First, you have to find out why they are asking that morphine that infusion, and also you have to find out the pain that pain assessment. You have to do the proper assessment. Have to find out whether they have actual pain or not. Then and also you can think about the addiction also.
Okay.
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 Mm.
Thank you.
Yeah.
And not IV. Where you
Yeah.
mentioned IV. Dangerous it is. Okay.
Yes, that's the thing. They are asking the morphine infusion, IV infusion.
That's all. So as that is one of the clue to say that probable addiction could be there. Okay. It is
Okay,
not,
ma'am.
as we always say, with morphine and all, is the patient really in end of life stage, or are they asking for morphine for something else?
Okay, ma'am.
No, that's why we all have to learn to save our skins also.
Mm.
Ma'am,
So there are multiple factors there. And if it is really end of life also, we give subcutaneous infusion, not IV infusion.
Okay, ma'am. Okay.
Because you
Not
mentioned
IV.
IV, it is not given IV.
Yes, IV infusion. It's low doses, 0.5 like.
ma'am, we have only 5 minutes. We have a
Yes.
case presentation. Can we move on to that?
Yes, please. Yes. I too
Georgina?
saw that and I was about to say.
Yeah. Are you there?
Ma'am, please unmute from your end.
I am there. Is she? Who
Yeah.
is going to? Is the person presenting?
Georgina, she is there, ma'am. She is there. Yeah.
Hello. Hello.
Yes, we can hear you.
Okay, thank you. So my name is Georgina from Kenya. So I have a case presentation. A female patient with age 38 years who had a diagnosis of cancer of the cervix, stage 3B. Also has obstructive uropathy, and she is seroreactive. The presenting complaints were pain at the lower abdomen, general body malaise, constipation, for smelling, pervaginal discharge, nausea, and vomiting. You can go on. History of illness, the medical history, patient on follow-up in the comprehensive care clinic. Surgical history, the surgery for nephrostomy tubes insertion was done. On an examination, the patient was sick looking, she was cachectic, dehydrated, moderate conjunctival paleness, severe abdominal pain on charge, restlessness, bilateral nephrostomy tubes in situ. So, laboratory investigations, she was done full blood count where white blood cells were 11.8 millimoles, which were high. Neutrophils were 8.82 millimoles, which are high. RBCs 2.57 millimoles, which are low. The HB was 7.9 grams per day. 7 grams per deciliter, which was low. The platelets level were 489. The creatinine was 38.2 millimoles per liter. Yeah. So the treatment and significant investigations, IV paracetamol 1 gram TID for 3 days, syrup oral morphine 10 milligrams for hourly. She was on follow-up, so she's on the heart 3TC stroke DTG stroke TDF, 1 tablet once a day. IV ondansetron 80 milligrams TID for 3 days. Fluconazole 200 milligrams every 72 hours times 3 doses. Syrup lactulose 10 mils TID for 1 month. IV metronidazole 500 milligrams TID for 5 days. IV ceftriaxone 1 gram BD for 5 days. And she was given blood transfusion 3 times. So continue IV fluids also, monitoring of fluid input and output chart, monitoring of vital signs, nutritional support for chemo. She was planned for chemoradiation at the referral cancer center. And that is at our level 6 hospital. Continued care of the nephrostomy tube. Psychosocial aspects. Patient married with 2 children being cared for by her auntie, who suspected as abandoned the patient in the ward. Weak social support, as when other family members have not been visiting her. As financial stress, was issued with a referral letter to the main cancer center for chemotherapy, radiation therapy. But she's unable. Patient feels lonely and in distress. Spiritual issues. Patient reports that no meaningful life. She has hopelessness. Main concern: involvement of a social worker to link patient and family members, involvement of a spiritual support, help patient on end of life care. The summary: patient admitted in the ward with a diagnosis of metastatic cervical cancer stage 3B, having comorbidity and with high hopes of prolonging life, had very severe pain, which was well controlled with morphine with the other distressing symptoms. Patient's condition deteriorating day by day. Our main concern is the delayed management of the disease. Discussion points. Number 1, how best can we help this patient who has a poor family social support and having no insurance cover? Point 2, is the patient able to benefit from the chemoradiation therapy if offered? Thank you.
Thank you, Georgina, for the presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. So, I hope this case presentation is clear to everyone. I think we are at the end of the session. I hope you are able to answer these questions. Please help Sister Georgina to help this patient. Please give your points and suggestions. Madam, what do you think?
See, thank you, Georgina, for the case. Like, see, these are the type
Thank
of things
you.
which you will come across. Okay.
Yes.
How good or what is the social care support that you have in your organization?
So, in our hospital, what we do, we usually encourage patients to register for the social insurance, which is a national scheme. So by the time I was giving out this presentation, the patient had no medical cover. So with time we followed up with the social worker, and also we have another NGO which is supporting our cervical cancer patients, stroke breast patients, which are Catholic body. So we followed up with the organization. She's getting a cash transfer of 4,000 Kenya shillings. So she was able to register for the medical cover, and it is ongoing. Right now, she was able to attend to the cancer medical center. As we are talking, she's a national cancer center unit. So by that time, she had so much social issues. The other issue was the relatives were not concerned. She was from a far distance from the hospital. And when we talked to the auntie, was the immediate caregiver, she was saying that it's only that they are able to offer what they can, but to an extent they are not able. So that's why we intervened with the organization.
Is there any non-government or is there any private setup which will be able to help her?
Not really. It's not there. It's only the one which was the one for the government, which is it's open to all members of the republic. So you are supposed to pay 500 Kenya shillings every month for you to have a medical cover.
Because see, this lady will need social care, financial support for looking after her children. And her main worry will always be, what will my children do when I am not there?
The children.
She will be worried, isn't it? See, you're telling she's day by day getting worse with her disease.
Yeah, she has several. Am I getting?
Did she know the prognosis?
Yeah, we talked to her about the prognosis, that she has comorbidities. We had to explain the prognosis of the diseases she has. Yeah.
So I think now what we understand from this patient story is this patient is having physical problem, psychological problem, social problem, and spiritual problem also. If these psychosocial issues are there, definitely her physical distress will be increased. So we have to find out some way to reduce her psychosocial issues, because nobody is there to support her. So we need to find a NGO, as Madam has mentioned earlier. So NGO who is supporting to this family, and so that will be a great thing for her. So this is we have to find out that kind of this the things there you have to find out. And also you can think about some financial things like small collections or something like that, and then that money you can use for her treatment, and also her children's educational things, educational support also. She
Yes.
might be worried about that also. So if these kind of NGOs there, that NGOs will support these
Yes.
things also. This after that she will be happy. So,
Yes, true.
so if you have to cover the 4 aspects, so then only we can
Yes.
able to improve the quality of life of the patient.
Yeah.
And
Thank
also,
you.
whatever that chemo radiation, whatever is available, she could at least attempt getting. It might give some either not whether curative benefit it will give, or it might give some palliative benefit. So first, give it a go and see if something will help her, or
Yes.
with few sittings, and then if that helps, well and good. If it's not helping, at least you can make a decision. She's not appropriate for that, and then at least give total supportive care. So because
True.
she's young, she has a young family also, whatever can be done can be tried. I know it is not easy with all what you say. She doesn't have insurance, she doesn't have family support. She's literally left there by herself.
Yes.
So that's what, as an institution and things, if you can, as Shiba said, outside support, anything possible, consider looking to every element to help her.
Yes.
That is what would be our
Okay.
suggestions to help.
Yeah.
You can come out of the screen, and if others have any other queries, we can go on to that and see Shiva.
Okay, ma'am. So any other questions?
No, ma'am.
No. So time up. I think we can wind up the session. So today we have covered an important topic, end of life care and medical ethics. Madam has explained well in detail. So I would like to highlight one major point, as Madam has mentioned last, food and fluids. That is one of the major concern to the caregivers, because food is a symbol of life, symbol of love. So even if the patient is in end of life care also, they will be suggesting like you can put a rice tube, nasogastric tube and give something. So you can give some IV fluid. These kind of compulsion will be there. So what you can do is you have to understand their concerns, their emotions. You have to talk to them, listen their worries first, and make them understand. So what are the benefits and harm to the patient, and then only they will understand about the harm. Okay, so that they that important things they may not know. So this is not going to help to their loved one. So that is also very, very important. So you have to think about the family members as a whole, because they are going to that miss their loved one. So they will be in emotion. So whatever, whenever you will get time, you have to be with the patient and their family. So that is the important message I need to convey with you all, because most of the time I would say like we are the persons spending more time with the patient. Even if the patient is in end of life care also, if you have get any time, so go and see the patient and be with the patients, give a that powerful that touch to the patient, and ask them. So whenever you come there, and you can see that patient that symptoms and all, whatever you have seen there, you have to don't forget to convey with the caregivers. That is also very, very important. Then and there you have to convey the truth to the patient caregivers. Okay. I think we can wind up the session now, ma'am. So thank you, ma'am, for the wonderful session, because for a short notice you took this session. Thank you very much. Thank you all for attending today's session. Thank you, Sister Georgina, for presenting a patient story today. So this is
Welcome.
this is the last day session. Your feedback is very valuable for us. Please feel free to give your feedback with us. If you need give any suggestions, definitely we will try to improve our course. Please don't hesitate to give your suggestions. Thank you, ma'am.
you and good wishes to all of you. And
All for joining us for today's session and for the entire course. So we are signing off from the Tips Eco Hub. Bye bye.